Now, the next topic is demyelinating disorders of CNS, part 2, NMO and MOGD. In this, neuromyelitis optica spectrum disorder. Neuromyelitis optica spectrum disorder. Now, what is this? Neuromyelitis optica spectrum disorder. Now, neuromyelitis optica spectrum disorder, it is also known as the Devick's disease. It is also known as the Devick's disease, and it is autoimmune in nature, as it is responsible for the humoral immunity and the antibodies that are used are anti-AQP4, that is anti-aquaporin 4. It is also known as Devick's disease. Neuromyelitis optica spectrum disorder. Okay, neuromyelitis optica spectrum disorder, it is also known as the Devick's disease, and it is humoral immunity in nature, and the antibody that is formed in this case is anti-AQP4, anti-aquaporin 4 antibody. Now, what are the clinical features? The clinical features in this case are bilateral posterior optic neuritis, because there is more than 3 vertebral segments myelitis. Okay, in this case, in the clinical features, there is bilateral posterior optic neuritis. There is bilateral posterior optic neuritis plus more than 3 vertebral segment myelitis. And in case of diagnosis, MRI is the investigation of choice. इसका मतलब ये कि जो न्यूरोमाइलिटिस ऑप्टिका स्पेक्ट्रम डिसऑर्डर है, इसमें क्या होता है कि it is also known as the Devick's disease. Okay, neuromyelitis optica spectrum disorder is also known as Devick's disease, and it is humoral immunity is seen in it as anti-AQP4 antibodies are found. In clinical features, bilateral posterior optic neuritis is present. Okay, bilaterally, not like multiple sclerosis, which is unilateral. And this optic nerve involvement is bilateral. Okay, and it is posteriorly, thus more than 3 vertebral segments are also involved in myelitis. Diagnosis is done by MRI, which is the IUC. And anti-AQP4 antibody test is positive. In this case, anti-AQP4 antibody test is positive. Now, what is area postrema syndrome? Now, in case of area postrema syndrome, it is highly characteristic of NMOSD and also intractable hiccups along with nausea or vomiting are seen. In diagnosis, MRI and anti-AQP4 is done. In area postrema syndrome, it is highly characteristic of neuromyelitis optica spectrum disorder, area postrema syndrome, and intractable hiccups are also seen, despite the nausea, vomiting. And what else we can do in we can do MRI, we can do this anti-AQP test, and we can also do the Wingerchuck criteria. Is followed for diagnosis. Wingerchuck criteria is followed for diagnosis. Now, what is Wingerchuck's criteria? In Wingerchuck's criteria, both major criteria are optic neuritis and acute myelitis. In Mendel's criteria, both major criteria are optic neuritis and acute myelitis, and at least 2 of 3 supportive criteria are also present, such as spinal cord MRI lesion extending 3 vertebral segments or more, brain MRI not meeting the diagnostic criteria for multiple sclerosis, and then AQP for IgG 0 positive status. In Mendel's criteria, both major criteria are there, such as optic neuritis and acute myelitis. Both major criteria are there, such as optic neuritis and acute myelitis. At least 2 of 3 supportive criteria are also there. Spinal cord MRI lesion extending 3 vertebral segments or more. Okay, at least 2 or 3 supportive criteria are there. Must be there. Besides the optic neuritis and acute myelitis, there must be spinal cord MRI lesion extending 3 vertebral segments or more. Brain MRI not meeting diagnostic criteria for the multiple sclerosis. There must be differential diagnosis in case of MRI, and the spinal cord MRI lesion extending 3 vertebral segments or more must be there. This must be called. Now, what is its management? First of all, we have the acute treatment. In acute treatment, high dose methylprednisolone 500 to 1000 mg per day for 3 to 5 days is done, followed by oral prednisolone for 11 days is given. Hey. High dose methylprednisolone is the acute treatment of NMO SD. Okay, it must be taken for 3 to 5 days, followed by oral prednisolone for 11 days, starting with methylprednisolone. After that, plasma exchange and IV immunoglobulins may also be considered as treatment. Okay, starting with high dose methylprednisolone 500 to 1000 mg per day into 3 to 5 days, followed by oral prednisolone for 11 days is given. Plasma exchange and IV immunoglobulins may also be considered as treatment. After that, relapse prevention. In case of NMO SD, it has a poor prognosis, and to prevent relapse, immunomodulators can be given, such as Okay, so in case of relapse prevention, NMOSD, it has a poor prognosis, and to prevent relapse, immunomodulators can be given, such as eculizumab, NTC5, eculizumab is NTC5, eculi. Remember it from eculi in case of relapse prevention. Eculi in abilizumab, eculi in abilizumab, anti-CD19. Eculizumab in abilizumab, anti-C5. In anti-C5 we have eculizumab, and in anti-C5 we have eculizumab. Anti-C5 is eculizumab, anti-CD19 is in abilizumab, anti-C5 is eculizumab, anti-CD19 is in abilizumab, and satralizumab is anti-IL-6. Okay, so the next is MOGD, which is myelin oligodendrocyte glycoprotein antibody associated disease. Myelin oligodendrocyte glycoprotein antibody associated disease. Myelin oligodendrocyte glycoprotein associated antibody. Myelin oligodendrocyte glycoprotein antibody associated disease. Now, what is the antibody that is formed in this case? It is anti-myelin oligodendrocyte glycoprotein. Anti-myelin oligodendrocyte glycoprotein. In this case, this antibody is present. Anti-myelin oligodendrocyte glycoprotein. Anti-myelin oligodendrocyte glycoprotein antibody is present, and it can be monophasic or relapsing remitting. Okay, anti-myelin oligodendrocyte glycoprotein antibody in this case is present, and it can be monophasic or relapsing remitting. Anti-myelin oligodendrocyte glycoprotein antibody, it is present. It can be monophasic or relapsing remitting. It can be monophasic or relapsing remitting. It is also present with optic neuritis plus acute myelitis. Okay, so myelin oligodendrocyte glycoprotein antibody associated disease. Okay, in this case, anti-myelin oligodendrocyte glycoprotein antibody is present, and it can be monophasic or relapsing remitting. Anti-myelin oligodendrocyte antibody assisted glycoprotein antibody assisted is present, and it can be monophasic or relapsing remitting. It is also present with optic neuritis and acute myelitis. Optic neuritis can be bilateral plus anterior, and acute myelitis is seen in less than 3 segments. Optic nerve is swollen, making it easy to differentiate from multiple sclerosis and NMOSD. In this case, the optic nerve, it is swollen, so making it easy to differentiate from multiple sclerosis and NMOSD. Okay, till now, what have we covered? Overall, pneumonitis optica spectrum disorder. In this case, it is also known as Devick's disease, and autoimmune humoral immunity is present. In MRI, it is investigation of choice. Anti-AQP for antibody test is positive, and Pinkerchuck criteria is followed for diagnosis. And acute treatment is high dose methylprednisolone 500 to 1000 mg per day for 3 to 5 days, followed by oral prednisolone for 11 days is given. Plasma exchange and IV immunoglobulin may also be considered as treatment and relapsing prevention. NMOSD has a poor prognosis. To prevent relapse, immunomodulatories can be given, such as eculizumab, inabilizumab, cetralizumab, and MOGD, anti-myelin oligodendrocyte glycoprotein antibody is present and can be monophasic or relapsing limiting. It is also present with optic neuritis and acute myelitis. But in this case, acute myelitis is seen in less than 3 segments. Okay, just quickly reading about the management. Okay, in case of the management, first of all, acute treatment is there. In acute treatment, high dose methylprednisolone for 500 to 1000 mg per day can again be given for 3 to 5 days, followed by oral prednisolone for 11 days is given. Okay, now plasma exchange. In case of plasma exchange and IV immunoglobulins may also be considered as treatment for relapse prevention. We can get rituximab for severe condition. We can get rituximab and azathioprine. Okay, so there are 3 types of demyelinating disorders that we have studied till now. The first one is neuromyelitis optica spectrum disorder. The second one is multiple sclerosis, and the third one is myelin oligodendrocyte glycoprotein antibody associated disease. Myelin oligodendrocyte glycoprotein antibody associated disease. After that, we will differentiate these 2 diseases on the basis of optic nerve, spinal cord, and pain. In case of optic nerve and neuromyelitis optica spectrum disorder, retrobulbar course is affected mainly. Okay, in case of optic nerve, retrobulbar course is affected mainly in the NMOSD, whereas it involves optic chiasm. Also, usually the retrobulbar course is affected. Now, what is the meaning of retrobulbar? It means behind the eyeball of the globe. Okay, such as this is the eyeball, and this is the orbit, this is the optic nerve, and this is the retrobulbar space behind the eyeball. Okay, mainly retrobulbar course is affected mainly, and it also involves the optic chiasma like this. After that, NMOSD is usually bilateral and it is retrobulbar. Usually in case of optic nerve, retrobulbar course is affected mainly, and it involves the optic chiasma. It is bilateral and retrobulbar. Okay, it involves more than 50% of the optic nerve. Okay. Next, in case of spinal cord, there is lengthy linear involvement. Okay, in case of optic nerve, in NMOSD retrobulbar involvement, the course was affected, optic chiasma was involved, and it was bilateral, and it usually involved more than 50% of the optic nerve. In case of spinal cord, there is lengthy linear involvement. There is more or equal to 3 segments are affected in this case, and the lesions are centrally placed. For example, this was the course, this was the segment, the lesions are centrally placed. Okay, in spinal cord, lengthy linear involvement is there. For example, this is spinal cord, lengthy linear involvement is there, more than or equal to 3 segments are affected, and lesions are centrally placed mainly, and it affects the cervical segments more. Now in case of brain, it affects the subcortex, whereas the corpus callosum is spared. Okay, in case of brain, it affects the subcortex, and in case of corpus callosum, it is usually spared. After that, MOGD, myelin oligodendrocyte glycoprotein antibody associated disorder. Okay, it is usually again bilateral. It is also bilateral and interior, just like NMOSD is bilateral, but in this case it is interior. Swelling of the optic disc is there. Swelling of optic disc is common in this case, and again it involves more than 50% of the optic nerve. And the lesions, they are usually centrally placed. Lesions are centrally placed again in the spinal cord, and they affect the lumbosacral segments more commonly. The lesions are there centrally placed and affects the lumbosacral segments more commonly. And in case of brain, involvement of corpus callosum is less likely. Mainly the brainstem is involved. And mainly the brainstem is involved. Okay, till now, in neuromyelitis optica spectrum disorder, it was retrobulbar and bilateral, and more than 50% of the optic nerve was involved, and it involved the optic chiasma, and it was usually bilateral. In MOGD, it was again bilateral, and again more than 50% of the optic nerve was involved, but in this case, swelling of the optic disc is common. Okay, now in case of spinal cord, lengthy involvement is there, and cervical segment involvement is there in NMO, more than or equal to 3 segments are affected, and lesions are centrally placed, and in case of MOGD, lesions are again centrally placed, and affects the lumbosacral segments more than the cervical ones. In brain, affects the subcortex, and corpus callosum is bad. In case of MOGD, corpus callosum is less likely, but not completely split, and mainly the brainstem is involved. Okay, and NMOSD is subcortex is involved, and from S we can also say segments centrally placed, cervical lobes, so sound. And after that, MOGD, mainly the brainstem is involved, and involvement of corpus callosum is less likely. In case of MOGD, involvement of corpus callosum is less likely, and mainly the brainstem is involved. Brainstem. After that, multiple sclerosis. Multiple sclerosis is unilateral, okay, not bilateral, and again retrobulbar. Just like this. It is again retrobulbar, and in this time, multiple sclerosis, it involves less than 50% of the optic nerve. In multiple sclerosis, it is unilateral and retrobulbar, and involves less than 50% of the optic nerve. And there is discrete or patchy involvement in spinal cord. Less than 3 segments are affected. And lesions are very fairly placed. Okay, in case of optic nerve, the multiple sclerosis, in case of optic nerve, in multiple sclerosis, the lesions are unilateral and retrobulbar, and in the involvement of less than 50% of the optic nerve is there. In spinal cord, peripheral. In this case, a lot of differences are there, such as involvement of less than 50% of the optic nerve, and discrete or patchy involvement in case of the spinal cord. And usually the periphery is affected. C3 segment is affected mainly in multiple sclerosis. And lesions are at the periphery. In brain, Dawson fingers, they are seen in affected portions of corpus callosum. Dawson fingers. For example, like Dawson fingers, for example, from side view of the brain. This is the normal structure of the brain. This is the brainstem. Okay. And this is cerebellum, and over here I see corpus callosum. Finger-like projections like these are seen over here. Dawson fingers are seen in affected portion of the corpus callosum. In multiple sclerosis, C3 segment is affected, lesions are peripherally placed, and discrete or patchy involvement is there. Okay, so now the best prognosis is seen in MOG. Best prognosis. Okay, the best one, it is seen in MOGD, myelin oligodentrocyte glycoprotein antibody associated disease. And the worst prognosis is seen in NMOSD. It has the worst prognosis. There's more than 3 segments are in it is the most retrobulbar. Now another important table. In this there is common features of optic nerve in multiple sclerosis, neuromyelitis optica spectrum disorder, and myelin oligodendrocyte type 15 antibody associated disease. Why? In helping to guide the clinical decision on diagnosis and course of treatment. What are the common features of optic nerve in MS, NMO and MOGD, helping to guide the clinical course on diagnosis and course of treatment? First of all, features. In case of features, we have and then multiple sclerosis, neuromyelitis optica spectrum disorder, MO, myelin oligodendrocyte glycoprotein antibody associated disease. Now in case of pediatric, let us go in alphabetical chronological disorder. In case of bilateral presentation. In bilateral presentation, in case of multiple sclerosis, is rare because we have seen that bilateral presentation is usually in NMOSD and MOGD. It is common in NMOSD and MOGD, then bilateral presentation is common. After that, course. In case of course, multiple sclerosis is relapsing or progressive. Course in case of multiple sclerosis, it can happen again and again, or it is usually progressive. NMOSD, it is again relapsing. In MOGD, it is monophasic or relapsing. Okay, so talking about the course, it can happen again. Multiple sclerosis, NMOSD and MOGD, they all can relapse. They can happen again. And multiple sclerosis is also progressive in nature, whereas NMOSD is not much progressive. So MS is usually more dangerous. Multiple sclerosis is more dangerous. And meaning of the monophasic course in MOGD. Okay, it means that the person can have a single attack or the episode of the disease, or it can be again relapsing. Okay, now what is the meaning of multiple sclerosis is progressive? It means there is neurological decline. In case of course, single attack or episode can be there. In case of MOGD and in multiple sclerosis, it can be progressive. So multiple sclerosis is kind of more dangerous. After that, CSF oligoclonal bands. What are CSF oligoclonal bands? They are very common in multiple sclerosis, whereas uncommon in NMOSD and MOGD. After that, it is some CSF oligoclonal bands are something similar to electrophoresis or chromatographic test. They appear something similar to that. And there are special bands, oligoclonal, they are kind of special bands that are seen as compared to the normal CSF bands. Till now we have studied the bilateral presentation, course, CSF oligoclonal bands. Now gender. All these neurological diseases are more common in females as compared to males. Now the MRIs. First of all, the MRI of the brain. In case of MRI of the brain, multifocal. We had seen those finger-like projections. We can also draw some finger-like projection. We can also call it multifocal. T2. Hyperintense white matter lesions. Okay, multifocal T2 hyperintense white matter lesions. And MRI of the brain may be normal in case of MMOSD, as more mainly subcortex is involved, but in case of MS, corpus callosum is involved mainly. Sorry, yes, corpus callosum is involved, and MOGD again callosum involvement is less, but still present. So maybe no. After MRI of brain, we will go to the MRI of spine. Again, multiple peripheral lesions are seen, so multiple focal lesions are there, and they are in NMOSD. Longitudinally extensive lesion is there, and conus is rarely involved. Longitudinally extensive lesions are there, and in case of MOGD again, central lesions are there now. So longitudinally extensive lesions are there. In case of NMOSD, cervical were there, and in case of MOGD, lumbosacral were there. Okay, and H sign is present, and conus lesions are there. Now what is H sign in? For the central part, it seems like an H is formed, okay? Just like that. So first of all, bilateral presentation, course, CSF oligoclonal bands, gender, MRI of brain, MRI of spine. And after that, ON swelling. Okay, optic nerve swelling. In that case, it is mild or none. We haven't read about it in MS. And in case of MOGD, it is commonly swollen. Okay, in NMOSD, so it is swollen, but less common than MOGD. Now after that, after the ON swelling, it is more mainly seen in MOGD. After that, pediatric presentation. Again, common in MOGD, rare in NMOSD, uncommon still, can be present in multiple sclerosis. Recovery. Okay, so based on the prognosis, we can say that MOGD is good. There is some risk of poor recovery in NMOSD, but it is very good in multiple sclerosis. Steroid response. It is again very good if needed, and is sometimes refractory in this case, and it is usually steroid responsive in MOGD. Steroid responsive MOGD, and MOSD does risk of poor recovery, and sometimes it is refractory. So steroid responsive recovery is very handy. Now visual acuity impairment. It is mild to moderate in case of multiple sclerosis, severe in NMOSD, and again severe in MOGD. Okay, I think till now that's all. Now so what we had studied yesterday on MOGD, just a quick recap of that. It is myelin oligodendrocyte glycoprotein antibody associated disease. Okay, and in this, which antibodies were formed? Was formed the new only anti-myelin oligodendrocyte glycoprotein antibodies are present, and it can be monophasic or relapsing remitting. Now what is the meaning of monophasic? It means that there is only a single attack per episode, or it can be relapsing. And the main symptoms are again optic neuritis, which are bilateral and interior. More than 50% of the optic nerve is involved, and swelling of optic disc is also present, and acute myelitis is there, less than 3 segments, and centrally there more affects lumbosacral segments. After that, the usually in this case, what happens is optic nerve. There is a problem here, that is optic nerve is swollen in this case. Okay, making it easy to differentiate from multiple sclerosis and NMOSD. This is a differential diagnosis of this disease. Now what is the management? In acute treatment, such as monophasic, high dose of methylprednisolone can be given for 500 to 1000 milligrams per day. Okay, methylprednisolone, and it can be continued for 3 to 5 days, followed by oral prednisolone for 11 days. First of all, methylprednisolone for 3 to 5 days, then oral prednisolone for 11 days. Then plasma exchange and IV immunoglobulins may also be considered as treatment. For relapse, okay, prevention, there is rituximab and azathioprine. Rituximab and azathioprine. Okay, but after MOGD, just quick recap of NMOSD. It is also known as the Davis disease, hemoimmunity, and anti-AQP4 antibody by the aquaporin. Okay, clinical features: bilateral posterior Cushing's syndrome is also highly characteristic of NMOSD. Interest hiccups and nausea vomiting are there. Now what is Wenger's criteria? Optic neuritis and acute neuritis are at least 2 of 3 supported criteria must be there. Spinal cord MRI lesion extending the vertical segment or more. Brain MRI not meeting diagnostic criteria for MS. Okay, this is a type of differential diagnosis. Acute before IgG seropositive status. Okay, acute treatment and relapse for acute treatment high dose methylprednisolone 50 to 500 to 1000 mg 30 for 3 to 5 days and then oral prednisolone for 11 days. Carbon exchange and IV immunoglobulins may also be considered relapsing prevention. NMOSD for prognosis and to prevent the relapse. Eculizumab, enabilizumab and satralizumab. Eculizumab C5, eculizumab C5, enabilizumab CD19 and satralizumab interleukin 6. Satralizumab, interleukin 6. Enabilizumab, okay, just remember, enabilizumab CD19, eculizumab C5, C5. Okay, that's it. That was the whole topic. Just a small note. Okay, for just again a small table. On NMOSD PQ4, in NMOSD aquaporin is involved now. So NMOSD aquaporin 4 IgG plus. Okay, in this case optic nerve, drawing the image. For example, this is the eyeball. These are the two eyeballs. These are the optic chiasmas. Okay. In NMOSD, bilateral. In NMOSD, retrobulbar pores and optic chiasma is involved. Okay, optic chiasma is involved. Retrobulbar involvement is here, and more than 50% of the optic nerve is involved. Okay. Now the second part is MOG IgG plus. In this case, MOGD anterior bilateral involvement is there, and more than 50% nerve is involved. And in case of multiple sclerosis, unilateral involvement is there. For example, these are the eyeballs. Unilateral involvement of present 50% of the optic nerve is there. Now after this, we have the spinal cord. For example, this is the whole spinal cord. And this was the diagram of the spinal cord. Again, this was the whole spinal cord. This was the diagram of the spinal cord. In case of NMOSD, which part of the spinal cord is involved? It is mainly cervical. Okay, cervical and central part is involved mainly. In case of MOGD, lumbocecal part is involved, and again mainly central involvement is there. In case of multiple sclerosis, C3 can be involved, peripheral involvement can be there. After spinal cord comes the brain. In case of brain, mainly for example, this is the brain. This is the corpus callosum. Mainly this subcortical area. Okay, this is involved. This is the upper cross section of the brain. Okay, mainly subcortical area is. This area is involved. In MOG, mainly the brainstem is involved. Okay, over here like this, brainstem is involved. And in case of multiple sclerosis, Dawson's finger-like projections is there. This is the brain. Okay, over here in the corpus callosum part, Dawson's finger-like projections are there. So that was the overview. So this was the whole topic of demyelinating disorders of CNS.